That is update on diabetic kidney disease, and to talk on this particular session I would like to invite speaker Dr. Sunil Kumar, who is a nephrologist, and to chair this particular session we have with us nephrologist Dr. Bismay Kumar, who is also the founder, member of scientific affairs of Howrah Diabetes Study Society.
A very warm welcome, Dr. Sunil. He is my old colleague, friend, and my well-wisher, like my own brother. We started working together in various hospitals in Calcutta, and also till last year he was there with me. Now he is in Apollo Hospital. He is an excellent nephrologist, academician, and today he is going to share us what new knowledge we have gained in treating diabetic kidney diseases and what is the recent advances in managing diabetic kidney problems. Over to you, Dr. Sunil.
Thank you, Dr. Bisham Kumar, for the nice introduction and the nice words. Very good evening, everyone. Today we'll talk about diabetic kidney disease updates. Shambhu knows. इसमें नहीं है. इसमें नहीं. Hall 2 में जो Sorry, it is taking some time. At the outset, I wish to convey my regards to Howrah Diabetes Society for inviting me over for this talk on diabetic kidney disease updates. I heard this previous lecture by Dr. Ipshita. She has done most of my some of my work. She has made my presentation easy. So I'll just skip the initial slides because it is just general information about diabetes and diabetic kidney disease. So regarding this update part, I think the update has always been come in the forms of decades. In the 1990s, prior to that, there was nothing. The patient used to lose their GFR at the rate of 10 ml per year, which makes almost like after 10 years of diabetic kidney disease, 100 ml of GFR loss will be there, and most of the patient will be an end-stage renal disease and on dialysis. When this ACE inhibitor came, they decreased the loss of GFR to 4 ml per year. So with this, most of the patients survived, and they also gave us some space to do to include them into further trials, like which we did in SGLT2 and GLP1 trials. And there are more data now to discuss about the CKD and its treatment. So, but in any day, the first thing which helped us decrease the loss of GFR was ACE inhibitors only, or ARBs. So diabetic kidney disease is one of the most common complications of the diabetes. Prevalence is steeply increasing. It's a common cause of end-stage renal disease. And global prevalence, we are the middle of somewhere near 500 million, which is too huge of a number, even bigger than any country. And by 2040, we are going to have 642 million patients of kidney disease. From this diabetes, kidney is arguably the most important target of microvascular damage. Approximately half of our patients with type 2 diabetes and 1/3 with type 1 will anyway develop diabetic kidney disease, irrespective of the blood sugar control or other controls. It makes sense to develop strategies and find causes of diabetic kidney disease and ways to retard the progression. So this slide shows the spectrum of kidney diseases in patients with diabetes. CKDs in the diabetes. Common causes will be diabetic nephropathy, added on by the hypertension, renovascular. Still, there can be non-diabetic kidney disease, which shares some part of subset with the diabetic group. Cause, we are well aware. I think has been discussed since morning in multiple slides. Across the hall also it is being discussed. Diabetes, excess of the sugar intracellularly leads to increase in the ROS and nitrogen oxygen synthase, which further leads to increase ROS and DNA damage, which further leads to ribonuclease. And what it does, it just straight away goes and blocks the most important part of glycolysis, GAPDH, which leads to accumulation most of the middle molecules, and which further ends up in the non advanced glycation products like polyol pathway, hexosamine pathway, PKCs and AG pathway. All these leads to accumulation of molecules which cannot be digested further, which stays in the body. That is the one of the reason we find normal size kidney in patient with diabetic kidney disease, because these are the molecule which sits there, keeps the kidney size normal, but they are of detrimental causes. They doesn't help us in any way. This when this is a biochemical level. If you see at the cellular level, this dark part is the diabetic nephropathy and the light part is the healthy one. The increased flux of this advanced glycation products or increased deposition of glycation products leads to thickening of the GBM, and in a way further leads to podocytopathy, podocyte loss through detachment and apoptosis, hypertrophy, foot process effacement, reduction in slit diaphragms and basement membrane thickening. In a way, this leads to increased EMT transformation and increased mesangial cell hypertrophy proliferation, which leads to further proteinuria, and which becomes a vicious circle and leads to further kidney damage. So this EMT transformation or epithelial to mesenchymal transformation is the one of the main key events. Some research have been done. Some people have tried to hit on that target, and some newer drugs like SGLT2, Finerenone, they have tried to hit on this target, and they have got some success, as previously discussed with Dr. Ipshita as well. In multiple trials with the initial advent of the cardiac trial. Thereafter, we included patients with the CKD as well. So this part is tubulointerstitial fibrosis is the one they have hit the most and found some result. So one of the earliest and the most characteristics of all GBM glomerular changes in the diabetes is a homogeneous thickening of the GBM. Thickening of the GBM is present in almost all the patients, and there is a strong link between mesangial matrix expansion and the progression of diabetic kidney disease. So it makes worth and important to attack this matrix expansion part, EMT transformation part. So further, I'll come to there are some changes which have been, there are some research or some new advances which have been done into the screening, estimation and treatment part, and some in transplantation. I take you through all of them one by one. One is the estimation of GFR. We knew there were some fallacies with the serum creatinine. With serum creatinine changes dramatically with the change in body muscle mass. It changes in the male is to female. It changes in the use of steroid, and there was always a chances of change in calculated GFR based on this serum creatinine. So thereafter we had multiple molecules, but one which could be standardized and had a similar reports, similar outcome for the GFR was cystatin C. So we started using cystatin C in the cases where there was always confusion with the serum creatinine, especially like muscular guys is there, or we expect that kidney size is normal, there are no urine activity and still serum creatinine is high. It can be because of thyrotoxicosis or other. So we started measuring serum cystatin C recently only. I think 3 or 4 days back I was going through one article. They have done a long-term outcome of the patients who were measured, whose GFR was measured based on either cystatin C or serum creatinine or both. They have seen that whenever there was serum creatinine was relatively higher than the serum cystatin C, which means GFR was shown relatively lower by the serum creatinine but better by serum cystatin C. They were the one who had the best mortality outcome as compared to those who had either cystatin C or the serum creatinine alone. So it is worth measuring both. We can measure, especially in those situations like athletics and a confusion group, we measure both serum cystatin C, serum creatinine, take a GFR and take an average of both. Though best will be using inulin and DTPase method, radionuclide method, but this is not feasible for the clinical purposes. So what we go usually do is to measure by using serum cystatin C and creatinine. estimating urine albumin excretion. Over a period of time, it has become important marker, important baseline marker, or numerical number of how much protein excretion is there. But there was some data which has shown that to begin with, to make a diagnosis, we should always do 24-hour urine protein as the first. Thereafter, on the follow-up, UACR suffice. So because of this cumbersome method, 24-hour patient needs to collect the urine over 24 hours. So doing initial 24-hour and thereafter UACR suffice for most of the purposes, except for the reason where we are planning to do a biopsy. For example, we have a patient not related to this place, like another place, lupus nephritis patient class 5, who have a proteinuria and UACR shows it is increasing. Then you can go for 24. Otherwise, most of the places in diabetic nephropathy, UACR is able enough to help us guide our treatment, whether proteinuria is increasing, decreasing, or stable or not. So there are some potential biomarkers which have been studied for the diabetic kidney disease. These are in blood and there are some urine. So they have seen that soluble tumor necrosis factor alpha, soluble fast ligand, FGF23. FGF23 is being done in some institute. Initially, when I was doing DM, this was a research molecule, but now for a bone marker and for as a marker of musculoskeletal disease, we some centers are doing the FGF23, TGF beta, BMP7, and other IL molecule. Uric acid commonly we do, and endothelial cell selective adhesion molecule, but none of them could be actually standardized except the uric acid and FGF23 in some places. So they are still there, but we don't know how to utilize it for the benefit of the patients. Same for the urine, we have multiple molecules, except for the some use in angle in patients who develops AKI in cardiac ICUs or CTVS. Most of these remains center specific, and we cannot use it across other hospitals. In the treatment part, this was about the evaluation part. In the treatment part, they have tried to touch these sectors like endothelial receptor antagonism, vitamin D analogs, membrane primary amine oxidase inhibitors, macrophage migration inhibitory factor antagonists, CCR inhibitors, pirfenidone, and novel mineralocorticoid receptor blocker, which was just discussed by Dr. Ipshita, phosphodiesterase inhibitor, mRNA therapeutics, and PPR inhibitors, advanced glycation end product scavengers. We have been working on this since last 10 years. Many centers, they have tried to scavenge these advanced glycation products, but ultimately none of them could show the clinical benefit. Factor erythroid receptor 2 related factor 2 agonists, NADPH oxidase inhibitors, urotensin 2 antagonists. So some gene as well, the people have tried to work on genetic as well as epigenetic part, and some centers, they are doing good in the epigenetic part. But genetic part, even my thesis in MD days was also on this ACE inhibitor. I did find this DD and II polymorphism double deleted or insertion deleted, but somehow most of this meta-analysis and long-term data from this genetic, they say that diabetes and diabetic kidney disease, they are polygenic. So we can't just blame on one gene and work on it. So rather these genes affect the exon part, the intron part or the epigenetic. So people are trying to find success over there. SGLT2, my job is done easier by Dr. Ipshita. She has discussed the same slide, that how this decreased activation of macula densa leads to benefit of using SGLT2 inhibitor, not just in the form of improving, decreasing the proteinuria and decreasing the loss of GFR, but also if we see carefully this part. Yeah. Sorry. Okay, anyway, I will use the cursor. So if you see this part, this is important, like not just this increased GFR in the hyperfiltration part of the diabetics leads to further loss of protein and thereafter EMT transition and fibrosis of this glomerulus, it is also detrimental to the tubule part. these tubule cells, they get damaged. This leads to increased HIF-1 alpha, which further leads to resistance and decrease in erythropoietin and hemoglobin and decrease hematocrit. That is why many people now, they almost, I think 3 or 4 research they are going on where they are trying to find out benefit of SGLT2 inhibitor in the terms of hemoglobin improvement, decrease iron requirement, which is a case in our CKD patients or diabetic CKD patients, apart from loss of GFR, proteinuria, and increased survivability in the terms of cardiac failures. So SGLT also has a role over here. The same slide. It just leads to SGLT2 inhibitor leads to normal glomerular capillary pressure, decreased filtered glucose and sodium chloride. SGLT2 inhibitor leads to decreased glucose and sodium chloride sodium resorption, which further leads to increased sodium delivery to distal tubules and reversal of vasodilatation and increased macular densa feedback. So based on this rationale, initially cardiac with some result, CKD kidney trials were done. Initially we had good outcomes with EMPA-RAG, CANVAS, DECLARE-TIMI, which had huge number of patients, 7,000, 10,000 and 17,000, and had a good number of patients who had the cardiovascular disease at the enrollment. Their primary outcome though cardiac, but they did show that the secondary in the forms of secondary outcome like proteinuria, change in GFR, the hazard ratio was 0.86 and 0.93 in the terms of major cardiac event, and in the terms of secondary outcome, in fact it was even better, though we can't say whether it was powered to see secondary outcome or not, but still hazard ratio was 0.54 in EMPA-RAG. In CANVAS, if you see secondary outcomes in the terms of progression of albuminuria, 0.7, composite of more than 40% decrease in GFR or needs of replacement therapy or kidney health related death, the hazard ratio was 0.6. It is almost 40% decrease from the control group. And similarly in DECLARE-TIMI, which are more of a cardiac, still they could show hazard ratio was only 0.53. So based on this euphoria, we jumped on to another further cardiac primary cardiac outcome trials, like we did involved almost 4,000 patients across credence, DAPA-HF, DAPA-CKD, and thereafter we had DAPA-GN trial as well, which included patients not just of diabetic kidney disease, non-diabetic kidney disease as well. So they could also show that in the kidney outcome hazard ratio of composite of ESKD, doubling of serum creatinine, kidney related or cardiovascular death hazard ratio was 0.7. In DAPA-HF again 0.75, and more or less their renal outcome was similar, either a loss of GFR or 40%, 50%, but their overall they could show that there was a benefit of use in patients with diabetic kidney disease, and their hazard ratio was 0.7. In DAPA-CKD, they could see the composite of more than 50% composite of more than 50% decrease in GFR, ESKD, and kidney related or cardiovascular related death. And the result, it is an old slide, result pending, but they could show there was benefit as well. Their hazard ratio was again around between 0.5 to 0.6. Yeah, 0.69, hazard ratio was 0.69. So this was a DAPA-CKD trial. And does dapagliflozin compared to placebo reduce the risk of kidney failure and cardiovascular event in CKD patients with and without diabetes? With this question, they started this trial. Result came in probably 2020-21. Yes, 2020. And 2000 received dapagliflozin and 2000 received placebo, and sustained more than 50% decline in GFR. Sustained, they use word because many times if we initiate ACE inhibitor or SGLT2 inhibitor, in the initial phase there can be rise of creatinine, but after a few weeks of this it stabilizes, it doesn't increase anymore. So that is why they say if there's after 1 month we always need to check for change in creatinine, change in GFR. If there is a continuous increase in creatinine, decrease in GFR, then we need to stop SGLT2 inhibitors. ESKD renal death, the hazard ratio 0.61, and sustained more than 50% decline in GFR, ESKD renal death 0.56, cardiovascular or heart failure hospitalization 0.71, all cause mortality was 0.69. So based on this, we went over to do the DAPA-GN trial. I could not keep a slide here, but DAPA-GN included patients of non-diabetic kidney disease. Like in this DAPA-CKD, also patient with diabetic kidney disease, some of them had IgA nephropathy and FSGS. Thereafter in DAPA-GN, they included patients with IgA nephropathy, MPGN, non-diabetic CIN, chronic interstitial nephritis patient, FSGS patients, and they could very well show that they also starting showing benefit in the terms of decreasing proteinuria and loss of decreased loss of GFR. Thereafter, based on these, we have started using and based on this, yeah, we have started using this ACE inhibitor with the caveat that we need to keep in our mind that it can lead to increase in creatinine in the initial phase, and there are some contraindication which we are well aware of, like complicated UTIs, structural disorders, as we just discussed in the last presentations. And based now we have GLP-1. The rationale of use of this GLP-1 is that it leads to decrease in inflammation. Sorry, NKF beta increased natriuresis and decrease endothelial mesenchymal cell transformation, which further leads to decrease in tubular injury, decrease in renal fibrosis, and decrease in glomerular sclerosis, leads to further renal protection. They also most of our kidney education, it comes from the cardiac trials first, since ages. This GLP also, they initially use it for the endocrine and cardiac purposes. And the secondary outcome was the renal. These are the secondary outcome in the leader trial, in which they use liraglutide versus placebo, and furthermore scale and lirarenal sustain. These three trials use liraglutide versus placebo. They could show macroalbuminuria, doubling of serum creatinine. They kept them as a secondary endpoint, and they could show that a lower incidence of nephropathy was found in groups treated with liraglutide due to a favorable impact of decrease in proteinuria. The GFR decline over the time was slower in patients with moderate to severe CKD. Thereafter we had some success with oral semaglutide. Macroalbuminuria, doubling serum creatinine was kept, and semaglutide also reduces the incidence of de novo macroalbuminuria. Nevertheless, no difference was found regarding the incidence of ESRD or death for renal cause. They also could say that because it is not a very long follow-up study, maybe on the long-term follow-up, this will show the benefit in the terms of ESRD or deaths. Thereafter, we have some more studies about lixisenatide, exenatide, dulaglutide, and all of them across the pattern, they have shown benefit in the terms of decrease in proteinuria. Though one thing I must share is that I was reading one meta-analysis, though it's not a trial which can be discussed. It was a meta-analysis. They were saying that in a meta-analysis, this GLP-1 analog is not able to show the decrease in proteinuria. So that is something which we need to keep in our mind before we start using this GLP for the renal purposes, or maybe we need to wait for bigger trials like this Novo Nordisk. They have now found this. They have now. I think I was having discussion with Novo Nordisk guys. They are going very good on this semaglutide and GLP drugs, and they are planning to put huge investment in the terms of this will be also used as a weight loss drug and all that. So as of now, these 4 trials are being conducted with the help of funds from Novo Nordisk, and they have huge number of patients. Almost 15,000 people are being included with semaglutide and oral, and they wish to know 2 outcomes trial investigating SEMA in diabetes related complication. One will be looking at the CVOT outcome, and there is a focus which is looking at the retinopathy. So maybe in the future they are basically betting high on this drug. So we need to keep an eye. Non-steroidal MRAs, we are very well aware now. There is some drug by the name of Finerenone. It has become available. This drug was being tested in 2014-15 in the rat studies. They had good benefit. Thereafter, it reached into. Oh, it's time. Yeah, I will just finish. I won't take much of your time. So this graduated into human trials, and Fidelio and Figaro study was done. And this is the this slide shows the actual difference between why spironolactone, eplerenone, and finerenone differs. Important thing is the distribution of the receptors or the distribution of the drug is equal in finerenone as compared to other drugs. Figaro study, they have shown that They have shown that the hazard ratio was 0.87 in the term when Finron was used. This was mainly cardiac. Thereafter Fidilo with the renal endpoint, decrease in proteinuria, improvement in GFR. Again, hazard ratio was 0.82. Fidelity, they just took data from the both and compared and showed that again that hazard ratio was low. I'll just skip these not important slides. Now this people have tried using this in combined Finneron and SGLT2 inhibitor, and the few trials like this confidence trial is underway. Maybe this will shed more light about the combination of use. Management of hypertension, not much is new except that these are the previous trial. I will not cover the ACE inhibitor which I discussed. There was a ACE inhibitor era in which we could give benefit to the patients. The only thing I will discuss is the combination of ACE inhibitor with the ARBs and ARNIs. Both of them, like Nephron D and altitude, they could not show any benefit, and in the terms of kidney renal outcomes. But caveat is that they did not include patients with the heavy proteinuria or non-diabetic kidney disease. Maybe you can still use in patients with a very heavy proteinuria and publish your result. I will just skip this hypertension. The endothelin receptor antagonists, they have shown some Sentence, they have shown some benefit in these trials in which they could use ET receptor antagonists. The only issue is that you need to make a subset of patients. Initially, you need to put all the patients on ET receptor antagonist and see only 50% of the patient will show benefit in the terms of changes in proteinuria, and take them and continue. Rest of the 50% of the patient need to be taken off your ET2 inhibitors. Kidney transplantation, not much new except that pancreas transplantation is gradually on the low decline because they have some success with the beta cell infusion, and in the transplantation as well, whether to do a simultaneous kidney pancreas or one after another. SPLT, simultaneous kidney and pancreas transplantation, have a better result as compared to the one after another in terms of multiple outcomes. And take home message is same which most of the things I have discussed: glycemic control, BP control, MRAs you can use, ET receptor antagonists, and urate lowering therapy is also important. They have shown benefit in the terms of prevention of loss of GFR and proteinuria in also in the diabetic patients. Yeah, there's good dietary changes you need to explain to the patients, as activity and long-term monitoring you need to do. Thank you.
SGLT2 inhibitor, they reduce renal hypoxia,
Yes,
renal oxygen requirement, and decrease glycation of renal interstitial tissue, renal fibroblast, so that fibroblast will secrete more erythropoietin. So is there such mechanism that they reduce renal oxygen requirement and glycation?
See, when this SGLT2 inhibitor came into being, when they were discussed in the same like these groups, when we used to go and discuss, this was a common question, like diabetes is a long disease. When glucose was there for years altogether, it led to AG, and thereafter it led to diabetic kidney disease. While SGLT2 is not decreasing the AG, it is just hitting the sugar only. So how is it beneficial? So later on search, it is seen that actually your both points are true. It leads to decrease in the subcellular inflammation and mesenchymal decrease in ROS activities, decrease in conversion from cellular to fibrotic pathways. So overall, yes, it decreases the oxygen requirement in the terms of inflammation and gives benefit not just in the terms of sugar requirement, but also it decreases the EMT transformation from the epithelial to mesenchymal cells, which leads to decrease in proteinuria and stabilization of GFR.
Because it increases erythropoietin level and hemoglobin.
Yes.
It has
Yes.
so many studies.
Yes.
Fibroblast may be hypoxic and
Yes, true. Absolutely true, yes.
Yes, sir. Thank you, sir. Thank you, Speaker, sir. Thank you, Chairperson. I would like to request Chairperson Dr. Bismay Kumar to kindly felicitate Dr. Sunil. Thank you, sir, for joining us on the 8th National Conference of Howrah Diabetes Study Society.